once we can get it uploaded. So I can see the screen has started there. So without further ado, I shall hand over to the haematology team. Thank you very much for volunteering to speak to us today.
Thank you, everyone. Hope you can see the slides and
yeah, we can.
Can hear me okay?
Yep.
Excellent. So I'm just giving you some small 20 minutes on what is plasma cell disorders, what's insight for primary care, where do we go from here. So what kind of interface we need to continue to support the for the population of Stoke-on-Trent and Staffordshire as a whole. So we're going to briefly talk on MGUS, then smouldering myeloma, what are the diagnostic tests, what other conditions can have the paraprotein that can confuse things, and then some time to have discussions around practicalities and what we can help from the hematology team perspective. So we all do protein electrophoresis for various reasons. We end up in seeing this spike in the gamma region, then end up in having abnormality. You've been alerted with a note to say there is a paraprotein being detected. It could be monoclonal gammopathy, or it could be myeloma. Speak to the hematologist and you contact us. So what is monoclonal gammopathy? We have plasma cells. They produce immunoglobulins, IgG, A, M, E, and K, D. We also produce some kind of light chains, which you have seen a few times, serum-free light chain tests we talk about in our letters. If there is a cancer develops in that, we call it myeloma. And it could be an intact immunoglobulin formed myeloma, or it could be just light chain only myeloma. More common is what we see is the intact immunoglobulin, and 20% is about light chain. And sometimes we do see no abnormality in the protein electrophoresis, no paraprotein detected, but they can still have bone lesions and symptoms related to it. Very rare, it can happen. There is a pre-malignant condition called MGUS, which is a precursor to myeloma that need to be aware of. And there is in between where the cancer has become myeloma but hasn't got any symptoms. We call it smouldering myeloma or sleeping myeloma. There is a unique condition called amyloidosis, came from same pathology, but it's completely different. The quantity of the protein may be very minimal, but they become more solidified and can affect the heart, lungs, spleen, some bones, and usually present with the cardiomyopathy in the way of restrictive cardiomyopathy or nephrotic syndrome. And then they end up in coming to my colleagues, and then we tend to pick them up afterwards after the tissue diagnosis. Let's move on to the MGUS. What is MGUS? Usually it's picked up by various tests. People coming with a back pain end up in having a protein electrophoresis, or they go to the renal physicians with the CKD, and it's part of their workup. They'll do that. Spinal team does it for the back pain. Immunology team do it for the infection purpose. Neurologist does it for peripheral neuropathy package of tests. And rheumatologists often do it as a part of osteoporosis workup, or if they have any abnormal scans, they'll end up in doing the tests. What is it? So it's a pre-malignant condition. It's asymptomatic. They do not have any symptoms, but they may have symptoms for different reasons, different conditions, and having had the test and they've been diagnosed with the monoclonal gammopathy. Usually the paraprotein is around 30 grams or less. And if we do the bone marrow, they have a less than 10% cancer cells. So more importantly, they do not have any end organ damage. The simple idea is CRAB features: no hypercalcemia, no renal function abnormality, no anemia, no bone pain or bone lesions on scans. So bone pain is a bit harder because almost everyone will have some sort of back pain at some sort of in their as we grow older, so it's always confusing and end up in having test. But the results output would clearly say that monoclonal gammopathy or not, and then you can decide to refer to us. So the risk of MGUS progressing to myeloma, because most of them being followed up by us or in the community, depends on where do they live. They have it tested 6 to 12 monthly basis. Usually the progression is about 1% per year. If they have a low risk, it's less than that. It's 1% every 2 years. Or what it means is out of 100 people, only 1 or 2 would have turned cancer next year. We know that who that people will be. They have a protein of more than 15 grams per liter. They usually be a non-IgG type, and they do have abnormal serum free light chains. We usually risk score them, and depends on the risk score. We say the low risk, high risk, and the intermediate risk. High risk tend to have a higher percentage of developing myeloma, 58% in 20 years, so 25% in 10 years. Still very small, but they end up needing monitoring on a regular basis. Whereas low risk is very, very low, only 5%, if there are no risk factors. So the risk stratification is quite important. So we do test them at the start to see what's the paraprotein level, what's the type of paraprotein, what's the serum free light chain ratio, and you will have the notification whether they're high risk or low risk. If they do wander in the community, and what the things to look for us to fast track referral to us, if they have a bone pain, back pain, fatigue associated with the anemia, if they do start losing B symptoms, very rare in MGUS turning into myeloma, but it can happen. And they started developing neurological symptoms, mainly in the way of back pain, sciatica type of pain, and getting weakness in the legs, usually denoting that there may be a cord compression or neurological compromise. They can get recurrent infections. If they do, mainly bacterial infection. UTI is not one of the things we see in myeloma. So ignore the urinary tract infection, but any other infections, we need to be mindful about it. And of course, on a routine test, if you see anemia, kidney function is deteriorating, and there is hypercalcemia, that's what probably prompted you for an urgent attention to us, so we can see them earlier than the scheduled visit. There are some patients who will be monitored on MGUS. They become smouldering myeloma. We tend to know them well, but they slowly progress, and it can remain indolent for quite a few years. I have someone who's had for 20 years, not progressed, with a paraprotein of 40 grams, still ongoing, no progression at all, even after we've done quite a few bone marrows in between every 3 to 5 years, nothing changed. So smouldering myeloma doesn't mean that we need to treat, so we will still continue to monitor. We still look out for the features of crab and looking for any end organ damage. If there are none, we call them as smouldering myeloma and continue to monitor them. So what is myeloma? What are the diagnostic criteria? What happens if we delay the diagnosis? What is the role of Benz-Jones protein, urine test? Why we are started ignoring these days? And we have small introduction about serum-free light chains and what is changing in Staffordshire pathology service in the future. So I'll go through them in small detail. As I told earlier, we're looking for CRAB symptoms, but sometimes you wonder, why do we need to wait for the hypercalcemia to happen, the kidney function to drop, anemia to happen? We have in the past been diagnosed people untreated early and compare them with those who had a symptomatic myeloma. There were no difference in terms of overall survival. Hence, treating early will not provide any benefit. So we need to see the symptoms. But at the same time, it's having back pain is needing lots of symptom control, and patient will end up in long-standing back pain and the morbidity associated with it. Or if they develop renal failure, then it's a different thing. So further workup we have done, we decided that if anyone has a plasma cell percentage more than 60%, even if they don't have CRAB, or if the serum free light chain ratio more than 100, or if they had more than one lesion in the MRI scan, we would say they are highly likely to progress to myeloma. We call them myeloma defining events, and we tend to treat them early. So when to suspect myeloma if we don't know anything, if we don't know that they have got this? So persistent back pain, 4 to 6 weeks. This is a Myeloma UK charity guide for the GPs developed with the help of various colleagues across the country. Spontaneous fractures, hypercalcemia, anemia, unexplained breathlessness. Bleeding and bruising is very rare, but it can happen, particularly if they have amyloidosis, peripheral neuropathy. So look out for these symptoms and have this test done. And if there is no paraprotein on the protein electrophoresis and the serum free light chain or a urine Bence-Jones protein is normal, unlikely to have myeloma, then you can focus on other areas. Most common one is the hypercalcemia. Very rarely we get to see the low blood count. So, but there is a guidance by the NICE to say if you have criteria of more than 3%, consider myeloma and investigate for it. I talked to you earlier about non-secretory myeloma, which is very rare. It can happen. The cancer cells have become so primitive that they don't have the capacity to produce the M protein or myeloma protein or paraprotein. It usually diagnosed by taking a tissue diagnosis from the bone lesions or the plasmacytomas, and then we treat them as myeloma, as there is no difference between these two types of myeloma, and prognosis is similar. There are myeloma which is very focal. We call it solitary plasmacytoma without any without any marrow changes, or sometimes it can happen outside the bone environment, like nasal cavities, sinuses, nasopharynx, and larynx areas. Usually they tend to be treated with radiotherapy. They don't need any chemotherapy treatment. There's another condition called plasma cell leukemia, which is much more aggressive form of myeloma. The plasma cells, instead of staying in bone marrow, they tend to circulate, and they need to be more than 20%. And recently there's a change when it's going to be 5% soon. And they tend to behave the same way. So we are changing the criteria to International Myeloma Working Group. They don't have much in the way of lytic lesions, and we could see it on the blood film, and it may be reported back to say there's lots of plasma cells. We usually send the additional test by the time the results reach you. Generally have a poor prognosis. We tend to treat them very aggressively. Small note about amyloidosis. Amyloidosis is basically similar lambda paraprotein. They tend to become solidified like egg white, and then again to stuck in the extracellular level in the myocardium, giving cardiomyopathy symptoms. Usually they have a stiff heart, diastolic dysfunction, heart failure symptoms, usually associated with the renal failure. They may have a proteinuria, and either non-nephrotic range proteinuria or a nephrotic range proteinuria, they can happen. So that's how we diagnose it. There are 4 kinds. AL amyloidosis, in other words, light chain amyloidosis usually comes from lambda light chain. It can happen as a result of myeloma itself, can coexist together, or it could happen as a Waldenstrom macroglobulinemia, which is a type of lymphoma. Usually have an IgM paraprotein. Some of the MGUSs can turn into AL amyloidosis without turning into myeloma, so we need to be mindful about their heart failure symptoms and the nephrotic range or nephrotic syndrome type picture. AA amyloidosis tend to happen usually people with the chronic inflammatory disorders such as rheumatoid arthritis. Common rheumatoid arthritis usually managed accordingly. There are very rare amyloidosis called the TTR amyloidosis or transthyretin amyloidosis can happen as a hereditary or non-hereditary in elderly population. There are lots of recent improvements in amyloidosis and the treatment of TTR amyloidosis, which easily be accessed through the National Amyloidosis Center, which I come in a few minutes later. So what is the management of amyloidosis? Similar to myeloma, we suppress the protein production by giving them anti-myeloma therapy, and they tend to stop the amyloid deposition, and our own body protein degradation mechanism removes the pre-existing amyloid deposit. It takes time, so the initial symptoms will be minimal. Symptom improvement will be minimal, but as they get better and better, it takes time, but it will improve slowly. Cardiac amyloidosis has a very poor prognosis. So AL amyloidosis we treat as myeloma. Amyloid-associated the inflammatory disorder, you treat the inflammatory disorder. The hereditary treated with the gene slicing treatment, preferably happens in the National Amyloidosis Center in London, Royal Free Hospital. It's a dedicated service. They help us to type the amyloid, what type it is, and they do the extensive assessment of the amyloid involvement by SAP scan, which is only available in London, nowhere else. And they also do genetic testing if it is considered to be hereditary. Then they advise regional centers to treat them if it is AL amyloidosis. I end up seeing them to treat them as myeloma and work accordingly. There's a rare condition called POEMS syndrome, can associate with the peripheral neuropathy, organomegaly, endocrine-related symptoms, and some skin changes. I have only one patient in the last 15 years, not many of them around. Waldenstrom macroglobulinemia, it's a type of non-Hodgkin's lymphoma, can have the same picture. Usually have an IgM paraprotein, sometimes IgG as well. But when we do the bone marrow, we could see instead of myeloma cells, we tend to see the lymphoma cells, and we treat them entirely with different chemotherapy and as a lymphoma and tend to improve. So if you do see paraprotein, doesn't always mean myeloma. It could be MGUS, it could be smouldering, it could be myeloma. Please refer to us and we will work around risk stratifying, and we will be able to let you know what's the diagnosis and treat accordingly. Sometimes we do see autoimmune type paraprotein, which usually tend to be transient, and usually a faint band and always disappears afterwards. So please repeat it before you make a referral. Then we talked about amyloidosis, we talked about POEMS, we talked about lymphoma. Some chronic lymphatic leukemia do have it. And there are heavy chain disease with the paraprotein, usually around the Mediterranean and the Middle East area. I haven't seen one here in UK. So, delay diagnosis. I'm just going to talk about the paraprotein, what it means to you. So we have the intact immunoglobulin. As I said, it is the highest number. Usually the paraprotein typed as IgG or IgA or IgM. And then we only have light chain only type. So you can see that there is a overlap between intact and free light chain. Some of the myeloma are just purely paraprotein only, and many have paraprotein and the abnormal serum free light chain and the free light chain only. So we can pick that up in the protein electrophoresis. Previously used to do Ben Jones protein, what we are trying to look at in the urine electrophoresis to look out for this kappa lambda light chains, which is currently being replaced by serum-free light chains. The reason is we don't get too many urine samples, always missing. So when we looked at it, do we really need urine test? So if you look at if you do serum electrophoresis, urine, and the urine immunofixation and serum-free light chain, we can diagnose about 100% of the patients. If we do only protein electrophoresis, we may miss about 13% patients. If we do only without serum-free light chain, the diagnostic one, we may miss about 2-3% of the myeloma patients. If we do protein electrophoresis and free light chain, we can pick all of them. And it's slightly reduced in amyloidosis, but 96% is pretty good. So the urine compliance of getting the Ben Jones protein sample varies according to lots of studies, sometimes even to the level of less than 5%. So we may miss about 48% of patients with myeloma without the serum-free light chain test. So I'll just quickly skip through. And if we have a serum sample, we can run through the serum-free light chain on the same sample, and we can get the 100% diagnostic sensitivity. So we are slowly trying to get rid of the serum-free light chain, urine Ben Jones test. At the moment, we are working with the North Midlands Cheshire Pathology Service to change the criteria slightly. It has changed in the International Myeloma Working Group, change in NICE guidance, and the recent BSH guidelines also suggesting to do serum-free light chain rather than Ben Jones protein, because we can get the validity quite easily with it, because one sample solves all the issues. So if we do suspect myeloma, we do serum-free light chains and the protein electrophoresis. If it's either of them are abnormal, we think it's myeloma, we tend to refer. So what has been agreed with the Cheshire Pathology Service is that if someone has abnormal paraprotein, reflexly they will do the serum-free light chain test at the same time if they suspect it is myeloma. They automatically alert the myeloma service. They email the pathology service, email me or my colleagues to alert that somebody with the sample from GP or from A&E or from somewhere else has got a quite abnormal protein. Can we look into it? And they automatically do the free light chain test. And then we usually inform the involved primary care or GP service to say, this patient has got myeloma, can you refer to us urgently? And we usually give appointment within that week or next week if we think it's myeloma. If you know it is MGUS, then we will send a note to say it is MGUS, please refer to hematology as per the guidance. So just a brief information about what is immunoglobulins, what is serum-free light chain. You can see that it's a heavy chain part of immunoglobulin and the light chain part of immunoglobulin. When the cancer cells produces this light chain, some of them could be purely light chain producing cancer cells. It could be kappa light chain or lambda, and that's what we tend to see. The free light immunoassay is quite useful to tell us. We normally produce kappa and lambda, so we would expect to see some of it. The normal ranges are noted here. Whereas paraprotein we don't expect to see paraprotein. So if it is abnormal, if it is there, it is abnormal. Whereas presence of kappa lambda light chain is normal. We have a reference range between 0.26 to 1.65. But in renal deterioration, they tend to stay in the system longer. So there is a different criteria for it. So you can see that the ratio could be as high as 3.1 to as low as 0.37, depends on the type of the light chain. So we quantify it in that way. So when we see the patient, we say this is normal ratio for the abnormal renal function. We look at the GFR, and if it is less than 3.1, we still say this patient has normal serum free light chain ratio. It's mainly because the kappa light chain is about 25 kilodalton, lambda is 50. They tend to be filtered through the glomeruli and then goes in the urine. That's how we diagnose the light chain myeloma. So as the renal function deteriorates for different reasons and not because of the myeloma, you tend to see that the levels tend to go up. Having said that, they tend to go up together, even though the lambda can be slightly higher than the kappa, so the ratio is very different. So what are we working on in our staff's tissue pathology service? So we developed this algorithm. If they have a serum paraprotein abnormal serum free light chain ratio, it clearly says kappa lambda ratio with a normal ratio is polyclonal, so hematology referral is not required if it's on its own. We have given a slight example here. In this particular result, both kappa and a lambda both are high and the ratio is within the normal range. It means of no concern. So usually some infection related or inflammation related or renal impairment related. So it does not require hematology referral. So what we need to look out for is the paraprotein, 30 grams. IgA means more than 15 grams. Serum free light chain ratio. What we have done is when working with the pathology lab, we put in a criteria to say anyone has a paraprotein of more than 10 grams, it will prompt you to say, can you check if there are myeloma symptoms? In that case, speak to hematology for an urgent referral. So this is a criteria being developed by various groups, particularly in Oxford, Southampton, and Manchester area. So if they don't have, say if they do have any of this or all of this, then refer to myeloma and urgent 2-week wait pathway. If it is not fitting the referral criteria, particularly the paraprotein is less than 10 grams, please do not refer on a 2-week wait pathway. If you have concerns, please speak to us, but we will end up in rejecting it because we know it's going to be monoclonal gammopathy. So then we say, okay, is it a high-risk MGUS? We look at the paraproteins and the serum free light chain ratio, and we suggest it's going likely to be a higher risk MGUS, and routine hematology referral is done. If it is low risk, there are guidelines across various parts, including the Oxford ICB. They have said to be monitored in the primary care. How do we do it? There are guidelines being developed, and what is a referral criteria for hematology when they've been followed up in case, as I said earlier, what the symptoms to look out for in that case. So a brief mention about our myeloma service, our myeloma and plasma cell disorder service. We have the Clinical Service Excellence Program from Myeloma UK. We have our own patient support group. We do provide patient peer support if even when they are required. We do have a whole body MRI service, which is unique to NatStaffs. We provide lots of support to Myeloma UK in terms of patient-related projects, inviting our patients to the Myeloma UK's projects, or our clinicians would provide support to them. We provide early advice to primary care if there are any urgent results we come through. We do have a MGUS telephone monitoring clinic. We have a new paraprotein clinic. We do see about 6 to 7 patients a week with the new paraprotein. So we have capacity, but not probably enough to meet the demand. We have myeloma clinic across both UHNM and county side. We flexibly see the patient across. We have open access for patients to come to see us. They don't need to go direct to the GP whilst they're going through the treatment. They can come directly to our clinics to be seen. We do have a clinical trial slots every day of the week, so we can squeeze in patients through that service. We do have a large portfolio of clinical trials. So most of your patients will be enrolled either one of those studies to participate in clinical trial. It provides them access to the new drugs, and also they also help us to generate knowledge for the future. So, in a nutshell, one in 3 patients with myeloma presents in the emergency care route. We don't want them to be emergency care route. So we do recommend both protein electrolysis and serum free light chain testing, and rapid diagnosis and treatment improves outcome. So I'll stop at that. Half an hour of protein electrophoresis and myeloma. I'm happy to take any questions. Hi, Mark.
Hi, Cam. So I was on mute then. Couple of probably more points than anything else. When obviously the serum-free light chains, will that be communicated out to us as GPs when that's sort of set up and available? Because obviously it sounds like it's not quite sorted from the discussions that you've had.
Negotiating, so it's coming soon. So
I
think it's lots of back and forth between the ICB level discussion, who is paying for the test. Invariably, all of them end up in having the test done anyway. So it's just a matter of finalizing that it's the test going to be done and somebody need to pay for it. So it's trying to sort out that issue. Basically, otherwise everybody agrees. Pathology service agrees. Clinicians agrees with it, and you guys want it, so why not?
And I think, obviously, practicalities of getting urine you've shown is difficult. When the other bit I was going to say is there's a couple of flow charts that you've put in your presentation. I think those would be quite useful to obviously be able to have and to use. So obviously, when we're practicing, we can look at sort of protein levels, because I'm not going to be able to keep all those in my head with everything else from that point of view. So I don't know whether you're going to allow your circulation in your presentation, or just perhaps those flow charts may be quite useful to either have here or somewhere centrally on a website that we know where we can find those as and when we need to. And the last point was obviously around sort of the primary care monitoring. I can see that obviously there is a need for primary care monitoring, but again, I think it comes back to your first point, is obviously if there's a lot more work being pushed out, some of my colleagues will probably be concerned about that sort of work being shifted from secondary care to primary care. So it's obviously that as an aspect of that, we need to be looking at how that's resourced as well, because that's obviously going to take capacity up in primary care as well.
Yeah. So the first question is about the availability of this flow chart. I think it's going to be part of the pathology handbook for you guys to access through what you normally do. We will keep it in a UHNM website at some point once we develop the myeloma side of website. We are in the process of working through that. So out of all the IMND's requests, this is on the background. It is contentious. The MGUS low risk monitoring is varied. For example, your colleagues in Cheshire, South Cheshire, they tend to look after all the low risk MGUSs. It's been always the practice. In North staffs and the staff in Sharon, it's very different and varied and depends on the individuals. So we have a big volume of these patients. So someone need to keep an eye on that. Hence the reason why hence the reason why we had this telephone clinic service. What we have started doing this, what we call patient stratified follow-up clinic, run by the coordinators, which we are starting fairly soon. So the issue is that it's not only about the diagnosis, about the morbidity and keeping them on check all the time. And every time they do the test, they're waiting for the results to come through and then chasing up. And that is much more than the benefit of just keeping them following up. That's a major issue. So there is a patient stratified follow-up clinic service coming through. Oxford has done a really innovative way that the pathology department, as in the immunology department, sends out the blood results on the blood forms on an annual basis to them to say how this blood test you're due for it. And then according to the algorithm, they write back to them to say there's no change or there is a change. Then they do alert accordingly. So the clinicians are not involved. They could see the other myeloma patients who are waiting to be seen or needing chemotherapy. So that is the service coming through. It may get a national attention, that maybe service innovation will come through in the future. I'm hoping that will come through and it becomes much more automated. So we don't need to speak to the patients. If patients themselves can put the symptom checker on the app and we tell the results and we set the criteria, and then patient just be notified to say you have a no change in your paraprotein and have a blood test in 6 months or 12 months time. That's what we need to achieve it, but it needs lots of coordination and technology, conducive technology to work on it. So yeah, let's wait and see where we move.
No, that's interesting. I mean, I think obviously the follow-ups are not only with the haematology, but it's obviously across the board, across all specialties moving out. So it's how we coordinate that in primary care. But I think it's good that we obviously need to look at innovative ways to pick that up. And obviously, I suspect you're probably linking with Gary 3 from an ICB perspective to see how we can move that forward. But no, I thought I'd raise that given the audience. So thanks very much for those.
Gary sent me the document. I just haven't had a time to look through and modify it. So we are working on it. So.
Brilliant. Thanks very much for your time.
Thank you, Mark. We don't have any other questions. We can move to the next speaker, I think.
Sounds good to me. Shall I share my slides or any more questions for Cam?
Thank you, Jane. Yeah, go for it, David.
Perfect. I'll just share my screen. Hopefully, can you see my slideshow on the left? Slideshow. How's that? Can you see my slides and are they advancing okay?
Yes.
Yes,
Lovely.
thanks.
Thanks, Georgina. Good afternoon, everyone. My name's David Sutton. I'm a haematology consultant at Stoke as well. And it's my pleasure to talk to you now about blood result interpretation, obviously with my perspective as a haematologist. What I'm going to try and do over the next half an hour, 40 minutes, is just help you do fewer, but hopefully more targeted blood tests, give you an understanding of what goes on behind the scenes, just to hopefully allay some anxiety, but most importantly give you a chance to ask some questions. That's the most important thing, because it's your time, not mine. I'm going to give you an approach to the common abnormalities and the common queries that we get often through the advice and guidance or the on-call side of things, and what I'm trying to do is going to help you decide what to do next in primary care, particularly what investigations to do next, but also give you a feeling for when to refer, when to monitor, and obviously when to worry and pick up the phone. Now, I'll happy to share these slides as well, so you can have copies of these afterwards. I'll try and pause every so often for questions, but I can't see anything other than my slides, so please shout out if you have a question, shout me down if I'm talking nonsense or you disagree as well. So let's start with the full blood count. And let's start with a caveat. And unlike some of the slides you just had from Professor Cam, the evidence base for full blood count abnormalities is far from certain, and in many cases is minimal. So I would always suggest that rather than looking at a fixed number, let's say a platelet count of 120 or a hemoglobin of 80, actually put that in the context of the patient's symptoms, because one patient will be stuck in bed with a hemoglobin of 80, the other person will be climbing Helvellyn and won't even think about it. So when you speak to us, paint the picture of the patient, not just the number. We tend to get numbers quoted at us, but we need that patient picture. So if in doubt, ask, pick up the phone or use advice and guidance. And the best starting point, something I was told early on as a haematology trainee, was that most of the time an abnormal full blood count is not a haematological problem. It's not blood or bone marrow cancer. It's generally the egg, not the chicken. It's just a sign of some other illness elsewhere in the body that's putting a stress on the marrow. So before we even get to blood results, I think it's important that we're aware that a lot can go wrong before the blood even gets to the laboratory, unfortunately. So please make sure your phlebotomists are comfortable in using the right tube and putting enough blood in the tube, because if you don't put enough blood in the clotting tube, we can't give you a result and you get an NA and the patient has to go through the rigmarole of coming back in. Clotted blood is also useless for most things, and blood that sits with your delivery driver as it goes around the rest of the county on a very hot day can break down the red cells, and you can get a hemolyzed or an NA result as well. So make sure your phlebotomists are happy and that they know they can phone the lab at Stoke if they're not sure about which bottle to use. When you get an abnormal result, the first thing is to look at previous results. I know this is sucking eggs, but I think these are really important points just to stress, because sometimes it's clear to us that is the case. So this is my team's league position. This is West Brom's league position over the years, and what is worrying is this downward trend. What's reassuring is this upward trend, and there's also a more stable trend. So when you look at hemoglobin that is low, is it completely normal a month ago? Has it always been about 100? Has it gone 140, 180? What's the rate of change? Because that's the key thing. What's the dynamics of this abnormal result? Particularly with white cells and platelets, because they renew within a week. So your platelet count today is going to be out of date this time next week. So what I want to see is the platelet count 80, and has it been 80 for 5 years, or was it 300 and it's now 100, then it's 80 on the repeat? So look at those previous results and give us that trend as well. And bear in mind that blood results are normally distributed, and the normal distribution implies that there will be a percentage of people, about 2.5% at either end, who are just above or just below the normal range, but they are not pathological. Just as some people can be very tall or very short without having a growth hormone tumour or growth hormone defect, you can have people whose hemoglobin or platelet count is just below normal, but that's entirely normal for them. And also, what is normal? Well, it's probably fine for me as a 40-year-old white male, but does normal apply to someone from a different part of the world? To someone who's 95? To someone who's pregnant? So don't just look at that red result, put it in the context of the patient. To mention very quickly behind the scenes, just to reassure you, if nothing else, you're not going to get a blood result on your desk at 6:30 on a Friday evening with an acute leukemia that hasn't been actioned. Any very abnormal blood result is flagged to us in haematology. And the biomedical scientists will look at the blood down the microscope. The oncohematologist will look at it. This happened last night with a white cell count of 280, and we will get the patient in directly for an emergency. So the first you may hear about it is the discharge summary, or you may see a blood film comment from us. That often comes through with the full blood count report at the end, and it'll either say we've admitted this patient, or it might say please discuss with us if X, Y, Z, if there's lymph nodes or whatnot. And Dr Talbot, my colleague, will touch on that in a bit. I'll apologise because we write lots of things on the full blood count that mean nonsense to you, and you end up having to Google them. Words like anisopoikilocytosis, toxic granulation. Effectively, that's us talking to ourselves, so that when we see the patient in clinic or we get a referral, we've explained things. But I would hope that we give you a clear conclusion at the end, a bit like a radiology report that covers lots of anatomy that we've all forgotten. But at the end, there's a clear conclusion that gives you an assessment and a plan. But if we write toxic granulation without any qualification, that is our fault, and please clarify that with us. It generally just means an infection. So first of all, let's have a look at red cells, and we're going to start off with sucking eggs. But I think it's really important to get these eggs sucked correctly. So a classic case that we get, very common, is a young lady, 30-year-old lady with fatigue. And that gets flagged to us because she's anemic with a hemoglobin of 98 and otherwise normal results, normal white cells, normal platelets. So the next thing to look at, and I'm sure this is a spinal reflex for you all now, is the mean cell volume. And that's really, really important because that's the key to differentiating your cause of anemia. And you can instantly remove 2/3 of your differential by looking at the MCV. And this lady's MCV was 70. So dead easy, microcytic anemia. We're all thinking, hopefully, about iron deficiency and thalassemia as our most common, kind of 95% of patients. So when you see that, very simple, straight to the patient. Have you had any bleeding? And that is typically GI bleeding. It can be more subtle things. It could be chronic epistaxis that's not enough for the patient to see a doctor. They'll say, oh, I've had nosebleeds, squeezed it for 5 minutes every other week. It may be young ladies with very heavy periods, which to them are not heavy or not deemed abnormal to them, but ask about heavy periods in youngsters. Ask about diet. Are they not getting enough not getting enough iron in the diet? And even if they are they able to absorb it properly? Are they having gallons of tea? Are they an early manifestation of inflammatory bowel disease, perhaps, or a celiac disease? Also, have a look at their ethnicity. Are they from a part of the world where thalassemia is more common? I've done this test in a room of doctors before, and I say, what's the best test for iron deficiency? And everyone goes serum iron. And I guess one of the key things I want you to take away from today is that serum iron is a useless test. I've got no idea why it's even reported. I honestly can't get a logical explanation. The test you need to do when you're thinking about iron deficiency is ferritin. Serum ferritin is the best marker of iron stores. Serum iron is useless. It depends how much meat you had for dinner, and if you test it in the morning, it's often different to the level in the evening. So look at serum ferritin, and remember that all we're doing in this workup is finding a symptom. We're finding a symptom of low ferritin with associated fatigue. What we're not doing is treating the cause or finding the cause. So don't stop there. Look for that bleed, look for that malabsorptive problem. We'll come on to that in a moment. But another key thing to remember about ferritin is it's an acute phase protein. So it will be elevated in people with concurrent inflammation. That could typically be your patient with undiagnosed rheumatoid arthritis who's taken ibuprofen, TDS. He's developed some gastritis, and that's what's made him anemic. But because of the active untreated rheumatoid, he's got inflammation and his ferritin is elevated. The general feeling is that a ferritin above 300 excludes iron deficiency. But when the ferritin is normal, particularly when it's 100 to 300, you still can be iron deficient if there's inflammation. So then look at the transferrin saturation, and if that's less than 20%, then that suggests there's an element of iron deficiency, and a trial of iron therapy could be helpful in terms of the patient's symptoms, because we don't care what the hemoglobin number is. We care about correcting fatigue. I think that's the key thing in hematology. Let's not treat the number, let's treat the patient. Thalassemia clues are normally quite obvious. It's people from the Eastern Mediterranean, Southeast Asia. They will typically have a normal ferritin, but they're very much entitled to get iron deficiency as well. And you can't diagnose thalassemia without a normal ferritin level, of course. But the real clue, the real kind of pattern recognition, is that they have a much lower MCV than they have hemoglobin. So they might have a hemoglobin of 100 and they'll have a MCV of 60, whereas someone with iron deficiency will often have a hemoglobin of 70 and MCV of 70, much more in parallel. So that kind of discrepancy is the clue. And also, if you look at previous bloods, they'll always had an MCV 60. They'll always have had a hemoglobin of 100, because that's their genetically programmed level. And for them, it's normal. It won't cause fatigue because they can carry oxygen just as well, despite the lower numbers. So if they are fatigued, look at other causes. Don't just blame it on the anemia. Their ferritin will be normal. And bear in mind, I think another key takeaway is that you don't need to be anemic or even microcytic to benefit from iron replacement if your ferritin is low. So iron deficiency anemia is the end product of severe anemia. Your bone marrow hasn't got enough ferritin, hasn't got enough iron to make blood cells. But there are lots of other organelles, lots of other cells in your body that need iron. And a low ferritin without anemia is associated with myriad symptoms: fatigue, brain fog, cold intolerance, bruising, itching. So if you see a low ferritin, don't wait for the anemia to develop. By all means, treat the patient if they're symptomatic, because they may well feel better. And when we look at ferritin ranges, increasingly we're recognizing that the ferritin range is very sexist. So I think our lab gives the ferritin as normal as low as 15. But actually, if you're a lady under 50 or a lady who's menstruating, then you likely need a level closer to 50, because your bone marrow is really running low. You've got almost no iron stores half the time. So I would say that a ferritin level of 20 is fine for me as a 40-year-old guy, but for a menstruating lady the same age, it should be closer to 50. And if they're reporting fatigue with a ferritin of 30, I would give them a trial of iron replacement. I wouldn't wait for them to become anemic whatsoever. How do I replace iron? Well, nowadays, and hopefully this message has come through to you now, we know that iron once a day is as effective as the old-fashioned TDS iron, and it's much better tolerated because you can't absorb more than once a day, and the extra iron just gives you diarrhea, constipation, dyspepsia, perhaps all three, and you end up not wanting to take your iron and you discontinue treatment. It's a slow burn, so it can take up to 4 weeks to have a response, either numerical or symptomatic. So caution your patients on that so they don't give up too early if they're not feeling better after a few tablets. And regardless of the cause, treat for a minimum of 3 months, but you may need to treat longer if you've not found a cause. If it's a 90-year-old atrophic stomach that's not going to absorb iron in the diet anyway, if someone's got menorrhagia from a fibroid that can't be removed, you may need to continue iron longer to maintain their therapy. There's ferrous sulfate, ferrous gluconate, there's citron and pediatric iron, there's ferrous gluconate. Generally, sulfate and fumarate have a fairly similar amount of iron in total, so they're probably equally tolerated. Gluconate's got a slightly lower iron content, and citron's got about half that of sulfate. So if someone's really struggling, you can chop and change, but it's rare that rare that if one doesn't suit them, the others do. We'll talk about intravenous iron in a moment, but just in terms of what do we do for iron deficiency? Obviously, we treated the symptoms, but what about the cause? So this is one of thousands of guidelines that you have to keep an eye on, and I don't envy you at all in primary care, but this is the British Gastro Guideline on iron deficiency, and it's quite helpful just to give you some structure. So it really highlights some key things that are often forgotten in hospital in particular. So when you've got someone with iron deficiency, particularly anemia, obviously think about GI bleeding, but don't forget about the small percentage of people who are going to have a renal tract tumour or celiac disease. So up front, you should be checking your patients for microscopic hematuria, and if that's present, think about imaging the renal tract. Have they got a renal cell cancer, a bladder tumour that's driving the chronic bleeding causing anemia? And about 2 to 3% of people may have celiac disease, so don't forget your celiac screens early on. Imaging is often limited to the bits of the bowel that the cameras can reach. So people will get a gastroscopy and some form of CT or actual colonoscopy, and then you'll get a letter back saying, no problem seen, refer to haematology. That comes to me, I will say nonsense. There's about 3 to 4 meters of small bowel that you haven't looked at. And your gastro guidelines will talk about investigating with a capsule endoscopy if there's no clear cause, particularly if they're not responding to oral iron. And if you haven't done so already, don't forget to think about the renal tract. It does recognise that there are some patients who have no obvious red flags. They are iron deficient without weight loss, without dyspepsia, dysphagia, without change of bowel habits. They have the investigations, they're negative. If they're responding to iron, then it's reasonable to say this is probably some form of malabsorption. We don't need to investigate further. But the worrying ones, the ones with the red flags, the ones who aren't responding to oral iron, and where we can help as haematologists is not with your capsule endoscopy. What we can help with is intravenous iron, which is a way to bypass the malabsorptive or the intolerance problems with iron. We can give a single dose of iron that can last the patient sometimes for 2-3 months. Sometimes it can just be the top up that they need after 3 pregnancies back to back over 12 months. Just pause briefly. Any questions anyone wants to ask or shout out at all? So
Could I just,
hello,
can I
yes.
just ask, please? Hi, sorry. Does this same apply to paediatrics as it does to adults?
This guideline?
Just sort of, I guess going back to the ferritin and supplementing, if the ferritin's low but the HB is normal, just because previously I've submitted quite a few advice and guidance regarding low ferritin for children. They don't recommend repeating or monitoring if the HB was normal.
Okay, I must admit I've not done any paediatric training for over a decade. I guess my main concern would be the young teenage girl who's having heavy periods, and that's rendering her ferritin low. And I would argue she would benefit from iron replacement rather than waiting for her to become anemic, by which point she'll probably miss some of her key education from fatigue and sickness.
Yeah.
But no, I'd stress the symptoms to paediatrics rather than just the number. I think that's the key thing to get across to them.
Yeah, okay, thank you.
Thank you, good question.
I mean,
Lovely.
most of the pediatric younger age is diet related, and as long as their diet is well managed, the iron deficiency tend to be improved. So that's the reason why pediatricians tend to say not to treat if they're just having a proper dietary advice would be more than adequate. But as David's example is pretty good, that someone is having heavy periods, having just attained menarche, then you have to treat it in a different way. So take it individual patient, individual person's concept, and then take it from there.
Thank you.
Thank you, Cameron. Thank you. So if we now jump to the other end of the spectrum, we get a lot of questions about raised ferritin and whether that's related to iron overload. So raised ferritin can be due to hereditary hemochromatosis, a genetic predisposition to absorb more iron than you need. But there's many other causes that are usually more common. When the ferritin is elevated, the transferrin saturation is the next thing to look at, and the lab tend to report that in parallel. And if you've got a raised ferritin and a transferrin saturation above normal, then that does suggest hemochromatosis. And that's where you can, if you're able to do the hemochromatosis gene assessment. But many times the transferrin saturation will be normal, and that's because ferritin is an inflammatory marker. So this may be a manifestation of chronic inflammation, dental disease, joint disease, their diabetic foot ulcer. But please remember that the liver is a big store of iron, and that can release a lot when it's irritated by alcohol excess, cirrhosis, metabolic liver disease. And some of our ferritin referrals, when we scan them, it does show that they've got some degree of metabolic or steatotic liver disease as well. There's a lot of debate about who should look after hemochromatosis, and it's kind of between us and gastro, really. Our general rule of thumb is if you've got someone with raised ferritin and abnormal liver function, then gastro are the best place to cover all the bases. But they'll probably say that if the liver function's normal, then hematology can do the venous sections. That's kind of iron overload in a nutshell. For patient reassurance, generally you need an iron level above 1,000 before you run into organ damage. A lot of patients get worried about an iron level of ferritin of 200. They end up looking at hemochromatosis on Google, and it tells them they're going to get heart failure and diabetes and kind of bronze diabetes, as they used to call it. But that's generally only seen with sustained elevated ferritin above 200. Sorry, above 1,000. If we move into the middle ground, if we look now at normocytic anemia, this is generally almost always the egg. It's almost always systemic disease stressing the bone marrow. So it's very common with the GFR less than 30 in chronic kidney disease. We see it and we describe it as anemia of chronic disease elsewhere. And don't forget that your people who are malabsorbing iron can also malabsorb B12 or folate, and they balance out with a mixed hematinic deficiency. So most helpful next tests are obviously your B12, folate and ferritin, but also things like immunoglobulins and CRP. Now, we're not doing immunoglobulins to look for myeloma here, and the report you'll often see is polyclonal immunoglobulins, which means all the immunoglobulins are elevated. That is a sign of inflammation, and the report often says consider inflammation, autoimmune disease, and again that's where a targeted history is helpful to work out the next steps. Anemia of chronic disease is often what we diagnose. It's basically chronic inflammation just suppresses the marrow's ability to make blood cells. That can be TB, rheumatoid, but more simple things like your chronic diabetic foot ulcers that are inflamed. You can see it with malignancy, although that malignancy is normally known, and it's generally the treatment and the chemo that's done that. And again, some chronic infections can do it. But also bear in mind, your 80-year-old who's fallen, broken their hip, had surgery, got COVID, gone to rehab, got C. diff, got pneumonia, and spent about 3 months in hospital. He or she will also generally have a degree of anemia that will take some time to improve once they're home and back on their own food again. And generally, this kind of normocytic anemia doesn't become too severe. It generally plateaus in the 90s, and you often see elevated platelets, elevated ferritin, elevated ESR and CRP with it as well. And it generally responds slowly but surely to treating the illness rather than just treating the blood itself. Macrocytic anemia is common, and 4 things to always think about are alcohol, liver disease, B12 and folate. They're the 4 things that account for over 90% of the macrocytoses. Good rule of thumb and a good thing to remember is that if your MCV is more than 110, then it's almost always B12 or folate that's going to do that. You might see it with a haematology patient taking hydroxycarbamide for polycythemia, for example, but it's almost always B12 or folate. It's much rarer for it to be a bone marrow pathology. You sometimes might see it with something called myelodysplasia, very rarely with myeloma. But we need to think about B12 because B12's deficiency is common. But another key point here is that B12 deficiency, only about 15% of patients will have macrocytosis plus minus anemia at the outset. There are another 85% of patients who may have other features, and you should still think about B12 deficiency even if the macrocytosis hasn't yet developed. So classically, I mean, that's what 18th century tongue abnormalities. I've never seen that outside a textbook, but glossitis, a big beefy tongue. They can develop thrombocytopenia before they become anemic. They can have memory impairment, and they can have neurological disturbance, which classically is kind of your peripheral sensory neuropathy. But it can also be more subtle changes. It can be an ataxia or a gait disturbance. It can be ophthalmoplegia or abnormal eye movement. So there's many situations where you need to think about B12. And that's probably 3 or 4 patients a day in your clinics, unfortunately. So the guidance really is think about B12 when these symptoms are there, but test for B12 when people have risk factors for B12 deficiency. Some of those are obvious. It can be someone who's a strict vegan. It can be someone who's had bariatric surgery, home or abroad, and isn't on adequate B12 replacement. It can be people who've had a lot of their small bowel removed because of Crohn's. But don't forget, common drugs can do it. So metformin, as was flagged a couple of years ago, induces B12 deficiency that is relevant, and it's generally with chronic use of higher doses. It can cause a clinically relevant symptomatic B12 deficiency. So think about that with your diabetic reviews. If someone's got diabetic neuropathy that's not improving despite the diabetes improving, have we looked at the B12? Has that been checked in the past year or so? And therefore they need treatments. There's another huge guidelines to look at if you have the time, but if you're stuck on B12, and the NICE guideline is actually very up to date, very helpful in talking about B12. It flags something I didn't know before, I not learnt, is that people abusing nitrous oxide can have symptomatic B12 deficiency, but it's a functional problem. So the B12 level in the lab is normal. You have to do other tests. So if you've got youngsters with unclear neuropathy or macrocytic anemia, ask them about nitrous oxide abuse, and then that will help you narrow down there or help move their care forward. B12 replacement is a common challenge. If someone's asymptomatic and someone's just picked up a B12 without any clear reason, especially if the level's borderline, so the B12 is more than 100, first instance really is just to repeat the level in 3 months, and to safety net and just advise the patient to report those symptoms of neurology if they develop. But if someone's got clear symptoms of B12, then general advice is to start with intramuscular replacement. That's typically alternate days, or practically that's Monday, Wednesday, Friday, for at least 2 weeks. It used to be 2 weeks for everyone, but the wording of the guidance is if someone's got neurological impairment, keep going until that's improved. So I mean, we had a lady on the ward a couple of weeks ago with subacute combined degeneration of the cord from severe dietary B12, and she was actually unable to walk and had started to lose sphincter control. So she's had B12 I think for 4 weeks now, and her neurology is improving. So we've given her alternate days for much longer. But for most people, you can, without severe neurology, treat alternate days for 2 weeks and then move to maintenance, which is usually every 2 to 3 months. And if someone's got a clear dietary cause that's not associated with malabsorption, this is when you can look to oral B12 and free up some time for your practice and your practice nurses in particular. Starting with oral B12 is difficult because if someone's got pernicious anemia or missing part of their gut, they're not going to absorb the oral B12 that you give, and that could worsen their symptoms. Moving to it is reasonable after time if the patient is fed up, but if they've got pernicious anemia, they're not going to absorb it because they lack the intrinsic factor. to do that. When you test for B12, test for intrinsic factor antibodies, but do that before you start B12 treatment, because once you're on B12, those antibody results are impossible to give, or to give a reliable result. If you've got intrinsic factor antibodies, that is very specific, very strongly suggestive of pernicious anemia, but the sensitivity is only about 60%. So a negative intrinsic factor doesn't rule out pernicious anemia, doesn't mean that oral B12 will be absorbed. So if you are giving oral B12, it is very important to check B12 levels after a month or so to make sure that they are coming up appropriately. Your body needs B12 to metabolize folate. So if you've got concurrent folate deficiency, my rule of thumb is to treat alphabetically. So replace B12 before you replace folate. Because if you start giving loads of folic acid while they're waiting for the B12 injection, you'll actually worsen the B12 deficiency. You might precipitate some new or some worsening of the neuropathy as well. Any questions about B12 or folate at all? There's often one or two that I've had. I try and adapt the talk to cover each time. Pooja has put a question in the box.
So excuse me.
Go for it.
Sorry. When we request for B12 and folate, sometimes the lab sends only the B12 result. They don't do the folate.
Oh, right. Okay. That doesn't make sense, does it? I don't know why they do that.
I don't know.
Is there a comment to say the folate was done in the past 3 months or something? Or
No,
is it just...
without any comment, they just do B12. There's no folate done. I have quite a few reports like that.
Okay, that is very unusual. I'd feed that back to the biochemistry lab. I don't know why they're doing that.
Thank you.
Yeah, sorry, it makes 0 sense. I'm stumped. Hello. Please shout out if you have a question.
Hello.
Hello, I can hear you now.
Hi, Nick Aldridge here. In those patients who are asymptomatic and have persistent marginally low B12, what do we do with those? Say, keeps coming back 170, 180. They're absolutely fine. What do we do?
So if they're asymptomatic, then there's an argument just to observe and monitor rather than treat.
Okay.
If it's asymptomatic and the level's less than 100, that's much more likely to develop symptoms within the monitoring interval.
Right. Okay. And once we've decided to treat somebody with intramuscular B12, is that for life? I've come across circumstances where people say, well, let's stop it after a couple of years and check the B12 in 6 months or 12 months. And I can't see the point in that. I think if somebody needs it, then they're on it for life. Is that true, or is that?
Perhaps, yeah. I mean, very much depends on the cause.
Yeah.
If it's someone who's a vegan who then becomes a carnivore, then that's the only time you could definitely stop. But if someone's got some kind of autoimmune gastritis or has simply had their resorption sites bypassed, it's not going to get better in the future.
Yeah. Yeah. Okay.
But yeah, the wiggle room is moving to oral, but that is not always possible for the malabsorptive cases.
Yeah. And there was an issue years ago with the test for intrinsic factor. That's no longer a problem, is it? I guess.
Not that I'm aware of. No, the only thing I'm aware of is that it's not a helpful test if they've started B12 replacement intramuscularly. Yeah.
Okay. All right. Thanks very much.
No, you're welcome. I've got a couple of questions on the chat as well. Helen Kumar has said, if B12 is due to metformin, replace oral IM. I think from memory, the NICE guidance suggests or favours intramuscular because it's thought to be a malabsorptive cause from metformin. So you might start intramuscular with metformin. So I'm looking at the questions. Lost track of where we are. So in terms of antibody testing, I would do it at the start. Gastric parietal cells are even less used, so I wouldn't necessarily do those first up. And I wouldn't wait for the B12 to normalise before starting folate. I would, once you've had a couple of doses of B12, get the folate going afterwards as well. And I think I've covered the other ones. The other question we get is, can patients have their B12 every month, every week? Because patients often find their symptoms don't improve fully, or they feel that they're dropping before the next B12 injection. NICE are quite helpful. They cover that, and they say the study dose maximum frequency is every 2 months. If patients are asking for it more frequently, then it's just a case about reframing it and saying, well, your symptoms may have other causes. We've taken B12 out of the equation, and we need to look at other causes for your fatigue or for your neurology. We don't need to give you B12 every month. Please don't buy it off the internet, like I know some of our patients have done, and taken it more regularly as well. Monitoring B12 replacement isn't necessarily needed. You like to get a level back in the thousands. You might want to monitor B12 in people taking it orally, because you're not as comfortable they're absorbing it. If you've got the rare patient who wants to self-administer B12 intramuscularly, then it might be worth checking it just to make sure they've got the right technique to do that. Now, I sometimes get a question about, you get a level of B12 that's 1500 in a patient, you weren't expecting it, and does that mean they've got cancer? So there appears to be some correlation between high levels of B12 and malignancy, and whether that's due to changes in how it's bound in the plasma is not really clear. We can see it with some blood cancers, some of what we call the myeloproliferative disorders, like polycythemia or thrombocythemia. You can see a high B12. In terms of it being the only sign of a solid cancer, I think that's really, really difficult. I think you'd have to go through your million things that NICE ask you to do about red flags. But it may be a case of there's other things there that are obvious, like the bowel habit, the change they've not mentioned, or the 2-stone weight loss that they thought was a good thing and didn't worry about as well. Okay, so let's move on to say that actually marrow pathology it was almost never manifested as an isolated anemia. You've normally got thrombocytopenia or neutropenia with it. Think about myelodysplasia, kind of your 70+ patients who have unexplained and progressive anemia. You've done all the tests that we've recommended, and they're still not getting better, and the hemoglobin is drifting down, and often it's slightly macrocytic as well. Heard all about myeloma from national experts. I'm not going to add very much on that. I can't get the slides. But generally, think about those crab features, think about those slim features that we might look at. But be reassured, it's very rare for myeloma to manifest just as an isolated macrocytic anemia. So when to refer to haematology? Well, number one, if we advise you to on the blood film, certainly if they've got other cytopenias, if they've got a big spleen, they've got lymph nodes that are enlarged, particularly if things are progressive, if it's unexplained, and very important if it's symptomatic, because we want to help people. We want to see people who are really struggling with their anemia. And it doesn't matter, like I said, if a hemoglobin's 100, if they can no longer do the exercise, the sport they did, please don't wait for it to get to 80. Please paint that picture, history, examination, then investigation. Give us a history, and that helps us put that number in context. I'm rubbish with a speculum. I'm rubbish with an endoscope. So if you've got fibroids, if you've got heavy menstrual bleeding, GI symptoms, refer to gastro or gynae directly. And if you see microscopic hematuria, then speak to urology, or think about a 2-week wait for urology. I'm hopeful you're better than me at managing B12 and folate. If you've got people who are really difficult, who are not responding or are asking about regular B12, actually think about speaking to the consultant biochemists that we have at Stoke, because they've got access to functional B12 tests, things like methyl melanoic acid, which can actually show if the body can use the B12 properly. So they may be the next step if someone's really struggling with B12 or is demanding of B12 every month. And if someone's got a GFR of 25, then speak to the renal team, because as part of their CKD workup, they may offer erythropoietin with the help of the renal nurses, plus minus a bit of iron. The renal team can help improve the renal anemia. At the other end of the spectrum is too many red blood cells. So we call this erythrocytosis. Rather than polycythemia, that implies it's a marrow disorder. And when we look at this, we look at the hematocrit, not the hemoglobin. So what we're generally looking at is hematocrit above 0.48 for ladies, above 0.52 for gents. That's abnormal. That should catch our attention. And it should catch our attention because there's a risk of thrombosis if this does turn out to be a primary marrow production. And the way I explain this to patients is that because of these extra red cells, your blood is more like honey than water. It's got a higher viscosity, it's thicker, and therefore it's more likely to clot. And that can be a stroke, it can be a heart attack, it can be a venous thrombosis in the legs or the lungs. Thankfully, as with most things, it's generally not a marrow disorder. It's actually a secondary cause. And fortunately, they're usually barn door obvious. They're your patients with COPD who haven't yet got home oxygen, the patients who are on thiazide diuretics, furosemide, the people who've had 6 pints the night before their blood test, the dehydrated, plasma depleted patients will have a raised hematocrit. Those with congenital heart disease with a left or right shunt will have that, but if you look at their trends, they'll be like that for years. But be careful with testosterone therapy. There's guidance about checking the hematocrit when you start it and of stopping it or avoiding the dose if its hematocrit rises. But I've had people buying testosterone off the internet, buying monthly testosterone and taking it weekly, and their hematocrit is 60%, and they've got a red ruddy face. They're generally quite grumpy, which can be a feature of erythrocytosis. So we'd like to help promptly if someone's got a very high hematocrit. So by all means, refer urgently if the hematocrit's above 60 for a gent or 56 for a lady. And if we can, we may write back with a bit of advice saying, please start aspirin 75 milligrams whilst awaiting the appointment, because we don't want them having a stroke or a heart attack in the 2 or 3 weeks it may take to get them in. We're also quite keen to see people urgently if the hematocrit is above normal and they've had a recent arterial or venous thrombosis, because their DOAC, their warfarin, may also need some venesection or other treatment to lower the red cell count to stop another clot. Most referrals, though, will be routine, and these will be the people whose hematocrit is elevated for more than 3 months, and they're not heavy smokers, they're not hungover, you can't find a clear cause. We want to see these patients. We don't want them to end up with a thrombosis and then get diagnosed. So we're quite happy to see them on a routine basis. And that's the hematocrit of 0.48 for ladies, 0.52 for gentlemen. And we'll also see people who've got thrombocytosis or leukocytosis, because that is more likely to suggest it's a marrow disorder. And the clues to primary polycythemia, or polycythemia vera as it's called, is a big spleen, aquagenic pruritus, so kind of itching after a hot shower or a hot bath, because those extra blood cells near the surface are kind of sludging the capillaries. And then something called erythromelalgia, which is kind of painful digits in cold weather, again because of sludging. Okay, so that's the bulk of things. Let's have a look at platelets. So I'm part of the thrombosis team. Platelets are a key cell to me, and they're a common cause of queries. Hopefully you're all aware of platelet clumping, which is effectively a spurious thrombocytopenia, meaning that it only happens once the blood has left the patient. So in the lab, the platelets are counted one by one by a laser. And in clumping, basically the platelets stick together like frog spawn, can't be counted. And if you did get a report, it would say platelet count of 10 and alarm bells would ring. But actually, this is just because the EDTA in some patients, particularly those who've had COVID quite recently, causes this platelet clumping. So what the lab will say is send a blue kind of coagulation tube. Frog spawn doesn't form, and we can measure and give you a true platelet count. And that's really important if your patient's on blood thinners, if you're doing the full blood count because of a bit of bruising, for example. Thrombocytopenia strictly is a platelet count less than 150. That's when the numbers go red. That's when things start to flag on electronic systems. But actually, most patients 3 times lower, patients with a platelet count of 50 or more, are going to be entirely asymptomatic. And for context, the risk of spontaneous bleeding only increases with a platelet count less than 20. So it goes red at 149, but the actual symptoms don't develop until it's less than 50, really below 20. So there's a big gulf in between. The patient's symptoms will tell us the level. So kind of spontaneous epistaxis with oral bleeding, kind of purple blood blisters, gum bleeding, often petechiae, are a manifestation of a platelet count less than 20. With 20 to 50, you might see spontaneous skin bruising or bruising after minimal trauma. A female patient might report a much heavier period. But once your platelet count's above 50, you're actually deemed safe for cardiac surgery, safe for a heart transplant, a new hip. So we wouldn't even give a platelet transfusion before hip surgery at 55. The platelet count above 100 is effectively hemostatic. That's safe for neurosurgery, spinal surgery. This is number. Obviously, if they're taking aspirin, if they've got an inherited platelet disorder, then the platelets may not work, whatever the number. But we get a lot of referrals from platelet count of 120, 130, and it's been like that for a decade. That's not going to be a cause of bleeding or bruising. It's going to be perhaps one of the myriad causes that is a lecture in itself. In terms of low platelets, think about immune causes if there's a very sudden drop. So your platelet count's normal, they have COVID, they have a flu jab, their new medicine, and the platelet count is single figures, and they come to you with easy bruising and nosebleeds. That's almost always immune. Think about liver disease, because liver disease often manifests with a thrombocytopenia. That can be quite mild in fatty liver. With more established cirrhosis, the platelet count can often run in the 70s, and the only way to improve that is to give them a new liver. Infection will drop the platelets transiently. Some medications can do that. I mean, if you read the BNF, every medicine causes thrombocytopenia, but look at the medicine. Did they start it? Has the platelet count dropped a few days afterwards? Are they pregnant? Because the normal range in pregnancy is different, and you can have a platelet count as low as 80 in the 3rd trimester. That is deemed normal for pregnancy. Is it hereditary? Is the platelet count 60? And the patient goes, "Oh yeah, my dad says his is always 60, and so does grandpa." Or have they got marrow disease? Most of the time, think of the liver. Hello.
I think it's 2:45 was a break time, so if you don't mind.
Oh, I'm sorry, I didn't realise.
If you want to just finish this topic off, and then we can regroup. If
I had no idea.
Yeah, hi. Yeah. If we could just have if you finish this section off, I'll send you all the questions from the chat, David, and then you can. I'll put them in the chat for the people who have asked the question. Sorry. If we could just have a quick 5 minutes after that, and then we'll move on to the next speaker.
Yeah, I'm really sorry. Of course.
Sorry, David. Thank you.
No, that's sorry. I'm just saying sorry. Got about 2 more slides. So yeah, but please think about the liver. A lot of referrals. The platelet counts are 110. We scan the liver. It's fibrotic, and we pass over to gastro. In primary care, ask about bruising and bleeding, but also think about constitutional symptoms, recent infections, recent vaccinations, recent medication, and dig into the alcohol history. Have a look for bruises, and classically with platelets we see petechiae, small red dots. Look for lymph nodes, but feel for the liver, feel for the liver edge. Refer to us urgently if the platelet count's less than 50. Speak to us also urgently if the platelet count's 50 to 100 and they've got anemia as well, or neutropenia, if you can feel a big liver or spleen. But also if they've waited best part of a decade for hip surgery, 5 years for hip surgery, the surgeon might defer it. But if you refer to us, we can put a note saying crack on with surgery, and they don't wait another 5 years for surgery. And obviously if they're pregnant, let us know. More routinely, if that platelet count is less than 100, that's when there's more likely to be a hematological disorder. That's when we can add more value by seeing them. Or any patient with thrombosis, because obviously they're going to be on anticoagulation. You want our reassurance that it's safe to carry on as well. Let's pause there, and you can have as long as you like. I'm really sorry to beat into your break.
Hi,
Wanna
everyone.
start
If we
again at
could
10?
just have a quick, if we could have a quick 5-minute comfort break, and then if everyone could join back at 5 minutes past 3 for the next session. Or do you still need to carry on, David? I've got George.
No, please.
No,
No.
yeah. Okay, so it's Dr. Talbot who's on next. Thank you.
Thank you.
Let me just ask one question, please.
Of course.
If the platelets are less than 50, you said, refer urgently after repeating the test. When should we repeat? How long should be that interval?
So generally straight away.
So if today is less than 50, can we repeat tomorrow and then refer?
Yes, that's what I do. Yeah, to confirm.
All right. Okay, thank you.
Okay, I'll see you in about 5 minutes.
Hi, Dr. Talbot. Are you ready to start your session?
Yeah, I'm here.
Hi, you're right.
Yeah, thank you very much.
Bruce.
I'll make myself visible. Hello.
Hi.
Harry, I think Dr. Sutton still have a few slides to complete, so then Dr. Talbot will do afterwards.
Yes, I can be
Okay.
very
Oh, I've got about 10 more slides, sorry, if you're not sick of me already.
Okay, no worries.
Okay, to get started again then.
Yeah, go ahead, thanks.
Lovely. So let's flip again from too many, not enough platelets to too many platelets, thrombocytosis. And again, this is just like with thrombocytopenia, just like with erythrocytosis, the worry is thrombosis. So small vessel thrombosis, ischemic stroke, TIA, heart attack, VTE. That's if it's a marrow cause. Most of the time it's not. It's generally infection, inflammation, because platelets are an acute phase protein. You can also get raised platelets in iron deficiency because your body's chucking out lots of EPO, and the EPO can overlap and cause thrombocytosis. And you often see people who've had a new hip or major surgery, the platelet count of 1,000 for a couple of weeks or so afterwards. It's quite rare for it to be a marrow disease like essential thrombocythemia. Again, thrombocytosis is flagged to you as one of the million things that can be a sign of cancer. Solid malignancy can be associated with thrombocytosis. It seems to be particular to GI and GU tract malignancy, and it's probably a manifestation of the iron deficiency you get with those. But I wouldn't CT scan everyone with high platelets. I would look for red flags for GI, GU tumours. I would speak to us if there's no clear cause, because it may be that rare myeloproliferative disorder. So look for inflammation, check the ferritin, look at the inflammatory markers. Refer to us urgently if the platelet count's more than 1,000, because that's a sky-high number that can cause bleeding. Paradoxically, because nothing makes sense in medicine, but if you've got loads of platelets, you gobble up your von Willebrand's and you can bleed even with a 1,000 or more. Refer to us urgently if the platelet count's above 600 and they've had recent thrombosis, they've got kind of vague neurology, TIA, kind of intermittent neurology, if they've got that bleeding, but also if they're over 60, because by default, by age, they've got an increased risk of arterial thrombosis, and we don't want them having a stroke because they're a diagnostic event. Just like with excess of red cells, if you've got an unexplained thrombocytosis above 450 for more than 3 months, refer to us because we don't want them having that thrombosis. And last but not least, coagulation testing. 3 key principles to take away. Number 1 is, first instance, just repeat all the abnormal coag screens, because you've got that black mark on the tube. If there's not enough blood in the tube, you can get a false result. You can get a slightly prolonged APTT, and it's unlikely to be anything sinister. Please bear in mind that a normal coagulation screen does not exclude a bleeding disorder, because it's just a screen, it's not a test. Also bear in mind that an abnormal coagulation screen does not always indicate a bleeding disorder. So we get people with antiphospholipid syndrome, which is a prothrombotic state, who've got an abnormal coag screen suggesting bleeding. So interpret those in the context of history. This is the key thing. I will see any patient, whatever their coag screen, I'll see someone with a normal INR, a normal APTT, if you tell me a history that's significant. If they've bled all their life, they've had heavy periods since day 1, they've gone back to the dentist because they're still bleeding the next day, their mum was a bleeder, their grandpa was a bleeder, they bled after surgery, pregnancy, that's the kind of thing I'm more interested in than whether the APTT is 1.19 and it's gone red. Have they got disproportionate bruising? Have they got bruises the size of a 1p piece after a minor bump? There's very different there. Describing bruises is variable. Please send photos if you can. That's always really helpful. Petechiae are typically kind of less than 3 millimeters. Purpura, big bruises more than a centimeter. Ecchymoses more than a centimeter. Purpura, generally nothing to do with haematology. These are kind of your red, purple, angry bruises. I mean, this guy's got a swollen leg, so he's probably got nephrotic syndrome driving it, hasn't he? So when you see purpura, think about rheumatology, nephrology, what's their urine protein level, have they got connective tissue, and speak to those teams, because there's not much we can add in haematology. But we can add a lot, excuse me, with hematomas. These are 3D bruises. These can cause a lot of anemia. This lady on the right had a COVID vaccine, and her GP phoned us up and went, I've got this lady, she had a COVID vaccine yesterday and her entire arm's purple and bruised. This is not right. The GP was quite right. They had a factor 8 level of 0.5%. This patient had autoimmune haemophilia, and their hemoglobin was dropping because it was all going into her arm. So tell us about the bruises, but also about the proportionality. And bear in mind that your coagulation cascade can be entirely normal, but if you've got Ehlers-Danlos, you've got flexible blood vessels that can't contract rapidly after injury, and you'll bruise easily. If you're senile, as they call it, if you're old, if you've had 90 years of sunshine without factor 50, you're going to have thin skin, thin vessels. And if you've had loads of steroids for rheumatoid or COPD exacerbations, you're going to get thin skin from those. And I reassure patients that this is just in your skin. It's not in your brain or your gut. It's generally a cutaneous manifestation only. So I'll finish off with a case history. Young lady, easy bruising, really common referral, advice and guidance once a week at least for us. The things I look for are the signs that it's a bleeding tendency. So heavy periods since menarche, they've had to have a suture after dental extraction, they bruise with minimal or no trauma, and grandmother was a bleeder, mum had a hysterectomy at 30 for heavy periods. All those kind of things suggest something's going on in the family. But you do your bloods, platelets are fine, blood film's okay, INR, APTT, even fibrinogen are normal. Please refer, because that is a significant history, and the screen is only a screen, it's not a test. I'm worried about a platelet disorder, even though the platelet numbers are normal, and I think there's going to be something in the family based on the grandmother and the mother. So this is a common manifestation, and we commonly pick up von Willebrand disease in this way. It's the commonest inherited bleeding disorder. About 1% of the population will have low von Willebrand levels, but only about 1% of that group will actually have bleeding. Unlike haemophilia, it can affect males and females equally. There's a huge variation in the actual bleeding pattern, and it can skip generations, and it can be more obvious in females than in males who undergo no surgery, pregnancy or periods. And thankfully it's normally mild. But please take away today that there will be young ladies out there who've had consults for heavy menstrual bleeding, have got as far as gynae and back, and no one has checked their von Willebrand's level. In studies, about 10% of ladies who make it to heavy menstrual bleeding clinics actually have an inherited bleeding disorder, but because there's no dedicated service, it's often missed, and these ladies are picked up in their 30s or 40s when they've missed time off work and school, they've had endless iron replacements, they've undergone hysterectomies. So please check von Willebrand's early, discuss with us for advice and guidance, and we can often get them in and get the ball rolling on the other areas. In terms of other tests, thrombophilia testing is useless. I wouldn't recommend testing for any inherited thrombophilia unless you want to help someone's insurance company charge them more money for their holiday or their life insurance. So factor V Leiden, prothrombin gene mutations add nothing to what drug we use, what dose we use, how long we treat for. It doesn't tell us anything, and as with most things, we can only test for what we know about. So the absence of a factor V Leiden mutation does not mean it's safe to have the estrogen containing pill in a lady whose mum and sister have had a blood clot. So there are many things we don't know about. Family history trumps the few things that we can test for. So in conclusion, I'll thank you for your time. I hope I've stressed the importance of symptoms over numbers, that most full blood count abnormalities are transient and get better with a tincture of time. And don't forget the liver is a really common cause of abnormal blood counts. Look at the trend, put it in the context, and please interact with us with advice and guidance. Hopefully that can be helpful. Thank you for your time. Sorry you had to hold your bladders in. And I'll take any questions before handing it over to Dr. Talbot, and if not, I can hang around till after she's finished.
I don't mind if you want to do questions first, David,
Okay.
while they're fresh in people's minds.
There is a question in the chat actually about if the platelet count is not at the level for urgent referral, how soon is intervals repeat done to assess the trend? From
Oh yes, yeah. From so that's it's quite difficult to give a and this is where there's kind of this grey area what to do. I mean, if the patient's well, if it's finding on a hypertensive review, then you might leave it 2 to 3 weeks because the platelet count will have renewed by then, and things that are significant will have showed up. If it's someone who's unwell, who's got some minor bruising, you might repeat it within a week or so just to check the trend more closely. If it's 450 and they're well with no inflammation, you might repeat that in a couple of months to see if it's still up to warrant referral on a routine basis.
Thank you.
Thank you. I'll pass over to Dr. Talbot then. Thank you for your time.
Thank you very much.
Hello, Dr. Sutton. This is Akhil. Hematology director.
Hello.
So she should be in 2 minutes. Sorry.
Okay. So that's the haematology registrar, Dr. Akhil. Dr. Talbot's probably.
Sorry, I'm here.
Oh, you're back. You're back.
Apologies,
apologies.
I thought you were going to talk a bit longer.
Sorry. If you finish sucking your egg, you can carry on now.
Is everyone able to see the PowerPoint presentation?
Yes.
And
I don't think it's in speaker mode yet. I think I can see your next slide as well. Or slideshow rather.
Slideshow.
If you go to display settings, Georgina, go to display settings. Oh. It's because you've got two screens open. You just need to flip it around when you open it. So open it as a slideshow again, and then go to display settings on your presenter view.
Display settings, yes.
Yeah, and then swap presenter view and slideshow. That one.
Is that better? And then can you see it moving? Thank you, thank you. My name's Georgina Talbot. I'm one of the haematology consultants also working at Stoke Hospital. I was given essentially leukocytosis, leukopenia, splenomegaly, and LDH. So I will try and kind of be clear about everything. Hopefully it's what you need. If you do have any further questions, I'm also happy to be interrupted. I can't see if hands are up or anything, so please do shout out. So within leukocytosis, I was going to talk about neutrophilia, lymphocytosis, and eosinophilia. Within leukopenia, I was going to concentrate on neutropenia, lymphopenia, and then splenomegaly and LDH. So when we are we've got a leukocytosis, so a raised white cell count, the bit that we are most interested in as haematologists, and I think would also help you to plan next investigations, is what part of the white blood cell differential is raised. Is it the neutrophils, lymphocytes, eosinophils, or a combination of all of them? So a neutrophilia is an increase in the neutrophil count above the normal range. This is often something that is reactive, so something that is acute, or something that can be a stress event, including things like a bleed. It's very rare for it to be an underlying hematological condition presenting just as a neutrophilia on its own. And really we'd be looking at a persistent increase or a continuous rise with the absence of an underlying cause to be concerned. You might see kind of blood film comments that point you towards indications that it could be related to a blood condition. So whether there are more immature white blood cells, these are called myelocytes, or whether there's nucleated red blood cells, or anisopoikilocytosis, which is essentially all of the blood cells that are all of the red blood cells which are being made funny and don't look quite round like they should. So in terms of things to think about when a neutrophilia is seen, infection, inflammation, is it a drug response related to steroids? Neutrophilia is common in pregnancy, it's common in smoking, and it's common in other underlying neoplasms that don't necessarily are not necessarily non-hematological. Apologies for that spelling, should not have an E and a hyphen. So kind of investigations that can help within primary care would be a full blood count. Often if the neutrophil count is high, you might notice that a blood film has been reported even though it wasn't requested. And this is just because of reflex adding these things in the lab for them to be looked at. You would want to consider doing biochemistry, looking for renal function, liver function, and LDH, calcium. The albumin is often within the liver function test and sometimes even a urate. As we're looking for inflammation, ESR or CRP may help towards that. And then within the clinical context, is this person a smoker or e-cigarettes? Neutrophilias can also be associated, like I said, with underlying neoplasms. So could symptoms like LUT symptoms be there and a PSA be needed, or any kind of rheumatological screen depending on the patient's symptoms. So who we would like to kind of see in clinic would be a significant persistent neutrophilia of greater than 15, which has been going on for kind of 4 to 6 weeks with none of the kind of following. So no obvious inflammation. There are concerning findings written on a blood film report. There is also significant changes in the other full blood count parameters such as anemia and thrombocytosis or thrombocytopenia. And also if the patient has got an enlarged spleen. Kind of transient neutrophilia, if it goes up and down, it's up for a little bit, then back into the normal range, then up again. That is less concerning and can often is often related to an inflammatory or an infective process rather than a hematological process. Obviously, when I say do not refer, what I still mean is please contact us via advice and guidance. It's just a clinic appointment may not be indicated. So if there are concerns, then please still reach out via the advice and guidance portal. And that goes for everything that I say when I say don't refer, rather than just repeating myself, if that's okay. Lymphocytosis. Obviously a slightly lymphocytosis is a lymphocyte count greater than the normal range, and the causes for this are different depending on the age group. It's something that is very common and again is reactive and doesn't necessarily require further intervention. If a cause such as an infection or an autoimmune condition can be found. Can also be seen in smokers and patients that have previously had a splenectomy. Younger patients, if they have a viral infection, typically do mount a greater lymphocytosis, and this is likely reactive. In older patients, a persistent lymphocytosis in that case is more likely to be an underlying lymphoproliferative disorder. So kind of things in primary care, a full blood count and blood film, looking at liver function tests. This is kind of the reason why I say liver function tests is this is in keeping with consideration of whether this could be a virally driven cause of lymphocytosis. So in particular, EBV does cause abnormal liver function tests and an enlarged spleen. It could also be the hepatitis virus, but also COVID. Examination is important. So is the lymphocytosis associated with lymph nodes and hepatosplenomegaly or hepatomegaly or splenomegaly? And then is there any evidence of any kind of red flag symptoms? Because that will help guide how to manage the lymphocytosis going forward. So any patient with a lymphocyte count of any number, which has got the red flag symptoms or the B symptoms, we would expect them to come via a 2-week wait pathway. Patients that have got lymphadenopathy and or splenomegaly and or cytopenias. So again, essentially a lymphocytosis with cytopenias, we'd want to see lymphocytosis with a spleen we would want to see as well. I would say we'd also, if you've just even done a one-off count and it's greater than 10, we would want to see those patients as well, again on a 2-week wait pathway. Patients that do have a count that is greater than 7 but less than 10, we would want to, and it's persistent for more than 3 months, we would want to see them if they remain asymptomatic, and this can be done often via a routine referral. Patients that we don't need to see in haematology clinic would be asymptomatic patients with just a single count greater than 7. We would recommend repeating the full blood count in 3 months and screening for viral conditions. And asymptomatic patients between 5 and 7, we would say repeat the full blood count in 6 months. And again, if there hasn't really been any change, it's likely to be a reactive course. But if there is a rising lymphocyte count at that point, at that 6-month period, we would want to see them. So eosinophilia. So this is, just going back to lymphocytosis. Just in terms of some of the things that we are doing at UHNM, you might start to see patients who have got a diagnosis of CLL, who are on active monitoring, who are being moved to a patient stratified follow-up. So this is a patient stratified follow-up, particularly for CLL patients. We are trying to refine the MGUS pathway, as Cam mentioned sooner, but the CLL pathway has been set up and has been started. So you may see patients that are having follow-up that way. Then we've got eosinophilia. So eosinophilia is a raised eosinophil count greater than 0.4, and the most common cause of eosinophilia is a reactive or a secondary cause, and this is allergy, eczema, drug-induced or parasites. After reactive causes, you may need to refer the patient to haematology to rule out a clonal eosinophilia. So in terms of kind of initial investigations, kind of clinical history in terms of allergy or atopy, review of drugs, any parasites in the stool, could they have a vasculitis, is there any pulmonary condition, is there any evidence of a non-hematological malignancy? Again, it is typically like kind of the prostate cancers or the end of life, even the small cell lung cancers, which tend to give a very, very strong white cell count response. So they can have a very high white cell count, which is a kind of a leukemoid reaction related to the underlying malignancy. There are patients that have Hodgkin's lymphoma that can have eosinophilia. Again, in these people, you can see sometimes a reactive blood picture, but they would often have symptoms in terms of B symptoms and lymphadenopathy. So you may not pick, it's unlikely to be picked up on an eosinophilia on its own, because they will have other symptoms. It's also important to consider travel history, just in back thinking about the parasites. So there are kind of some concerning flags to look out for if the eosinophil count is greater than 2.5. So these include recent VTE, or if they've got sudden decompensated heart failure, if they've got diarrhea, if they've got kind of unusual neurological symptoms, and any kind of shortness of breath or pulmonary infiltrates on a chest x-ray. So investigations, full blood count, a film, CRP, and using these LFTs, LDH, checking the stools, and considering a repeat full blood count if it is less than 1.5. So we would want to see patients with a persistent eosinophilia of greater than 1.5 with no underlying obvious cause. We don't need to see patients with a reactive eosinophilia if they've got other inflammatory conditions. And patients that can have persistent unexplained mild eosinophilia can sometimes be given a diagnosis of idiopathic eosinophilia once secondary causes have been excluded, and we would recommend those patients being monitored 6 monthly, and if their count did go greater than 1.5, then they should be referred. Are there any kind of particular questions at the moment? Is that a good place to pause if anything has come through, or happy for me to carry on at the moment?
Can I ask, please, with regards to lymphocytosis, would you recommend ultrasound scan, or would you just base the absence of enlarged spleen and liver on clinical examination?
So I think I wouldn't routinely recommend ultrasound scan imaging if examination has been negative. If there is a lymphocytosis in a spleen is felt, then I would expect a 2-week wait referral. I wouldn't necessarily. Are you talking about if it's kind of between 5 and 7, or are you talking about a particular lymphocyte count?
I would say in between 5 and 7, and then you're trying to see them clinically, assess them. Probably the blood was just done as a routine test, and in trying to work them up to eliminate possible causes.
I mean, if there's no spleen on clinical examination and somebody is happy with their examination technique, then I wouldn't recommend routine ultrasound scans in those patients. If the abdominal examination is uncertain, then there's no reason why an ultrasound scan can't be done. But I would only kind of recommend that in uncertainty after abdominal examination. Does that make sense?
Yes, thank you.
So then we have, if we move on to a low white blood cell count. So again, it's important to look at the differential. So neutropenia. So neutropenia, again, is a common condition, doesn't necessarily mean that it is related to an underlying hematological cause, especially if it is isolated and it is transient. So typically a neutrophil count of between 1.5 and 2 tends to not hold too much clinical significance. Patients with a mild neutropenia are not generally at increased risk of infection, but that's important to think about. And there are multiple drug causes for neutropenia, including some very common medications, the anti-psychotics, benzoyl NSAIDs, and the anticonvulsants as well. So kind of for all patients that have a neutropenia, infection history is important. So is the neutropenia causing clinical, is the neutropenia clinically significant in the fact that they are getting recurrent infections? It's important to establish the patient's ethnic background, medication review, examine again for lymphadenopathy and for any splenomegaly. If there's an incidental finding of a neutrophilia on a full blood count, then a repeat is important, including things, as David mentioned, like checking the B12 and folate. And that can be done between 4 and 6 weeks if they are clinically well. If the neutrophil count is less than 1, we would recommend a repeat in 1 week just to see if it was persistent or not. Other blood tests include a blood film, as I mentioned, B12, folate, ferritin, and also viruses can cause a neutropenia as well. There are also autoimmune conditions which can be associated with a neutropenia purely by having the condition on its own, but also related to the medication that they may be taking to treat their condition. So we would want to see anybody urgently with a neutrophil count of 0.5 and evidence of sepsis. It's fine to kind of contact the on-call hematologist, but really the patient will need to likely be going to their most closest emergency department for urgent intravenous antibiotics. The neutrophil count of less than 1 on repeat testing, and that's with or without any other cytopenias, would quantify a 2-week wait referral, or depending on if that might also be recommended on the blood film review as well. And a neutrophil count of less than 2 in the presence of kind of any other clinical features such as a splenomegaly or a lymphadenopathy, that would also warrant a 2-week wait referral. Patients that do have, so that are not white in origin can often have a constitutional neutropenia, sometimes described as an ethnic neutropenia, and again that goes back to the normal ranges and the fact that the normal range was devised on people of different ethnicity, of a different ethnicity to them. And if they are well, they don't have any problems, their neutrophil count is greater than 1, then often this doesn't require any further monitoring. If their neutrophil count is less than 1, then it's important that they are managed as per the above. Neutrophil count that is consistently greater than 1.5 but less than 2, it is likely to be just a chronic idiopathic neutropenia and doesn't often need further monitoring, again if the patient doesn't have any regular infections or any other cytopenias or any other drug causes. In terms of monitoring, it's probably worth keeping an eye on the patients that are well, but their count is between 1 and 1.5, and kind of that can be on a 6-monthly basis. And then obviously if that changes, then and it falls, referral to haematology would be important. And again, any questions, it'd be it's always a we're always happy to discuss it, and kind of for these patients, the advice and guidance portal is probably the best place to discuss. So lymphopenia, this is very common. It is very well known that as people get older, their lymphocyte count reduces, and it's rarely of any clinical significance. A lymphocyte count greater than 0.5 without any symptoms or any other blood count changes is normal and doesn't need monitoring. Lymphopenia itself may be a stress response. In terms of, it can go down in viral infections, it can go down in related to surgeries. And there are obviously sometimes drug causes that can cause it as well. Steroids can cause a neutrophilia, and with that at the same time can cause a lymphopenia as well. And these are often reversible on the cessation of any treatment or the recovery from infection. And it's always important to consider whether this could be HIV for unexplained lymphopenia. So blood tests, again for blood count, B12 and folate. Helpful to get quantitative immunoglobulins and serum electrophoresis, and then consider checking for viral causes or consider checking for other autoimmune conditions, and do they have a history of recurrent infections. So if there is a patient with a lymphocyte count less than 1 and they have got B symptoms, this can sometimes be related to an underlying lymphoproliferative disorder, and obviously the presence of the B symptoms would warrant a 2-week wait referral. Patients that have a lymphopenia that may have a lymphadenopathy or a splenomegaly, again we would like to see these patients on a 2-week wait referral. If the patients have a lymphopenia that's associated with a paraprotein, in particularly an IgM paraprotein, then again this could be an underlying lymphoproliferative disorder, and we would want to see them also on a 2-week wait basis. Lymphopenia, if they've got recurrent infections, it may be more suitable to consider an immunology referral because this may be a constitutional condition if they are getting regular infections. So kind of when not to refer, if the patient, if they've got a count greater than 0.5, if they're more than 70, they typically don't need any further investigations if the above are all negative. Spleens. So splenomegaly, this typically denotes a palpable spleen. You can also see a spleen splenomegaly being diagnosed on ultrasound scan, CT scan, or MRI scan. And it can really be quite variable from a mildly enlarged spleen to kind of a massive splenomegaly, kind of all the way down into the right iliac fossa. Also kind of trajectory of spleen increasing in size is also important and can help guide towards what the underlying cause could be. So the spleen is just a big, basically, lump of white cells that are kind of doing the job of filtering the blood, kind of there's kind of the red pulp and the white pulp that are involved in kind of getting rid of the old red blood cells, but also screening for infection and managing certainly particular type of organisms that are capsulated. It's also very, very closely linked to the liver, and also can be enlarged and related to cardiac failure. Autoimmune conditions such as rheumatoid arthritis, you can get the condition of Felty syndrome, where you have an enlarged spleen and a neutropenia and rheumatoid arthritis. It can also be enlarged in Gaucher's disease and sarcoidosis, but then also again in hematological conditions, so autoimmune hemolysis because of clearing out those red blood cells quickly, hereditary spherocytosis, so an underlying blood condition, a genetic condition where because the structure of the red blood cell is slightly differently, then its half-life is shorter, so it gets cleared from the system sooner. Myeloproliferative neoplasms, so you can have an enlarged spleen in polycythemia vera, myelofibrosis, leukemias and lymphomas. So the other thing to think about is spleen size is also related to height size, and you can sometimes find, well, you can find calculators kind of via the medical calculator apps to see if the spleen size does actually correspond to a patient's height, because certainly in the instance of an imaging report, the patient's height may not be known. So actually a spleen of 13.8 centimeters, which has been described as splenomegaly, but the patient is 6'4", would actually be appropriate. And in that situation, running it through the calculator, making sure you can't palpate it, that's typically all that's needed to be done. In terms of other investigations for blood count, blood films, is there any evidence of infection? And then looking for things that we look for hemolysis, so that's reticulocyte LDH. Looking at liver function tests, so are the liver function tests abnormal, pointing more towards a liver cause? Is the LDH raised, but there's also a leucocytosis or an erythrocytosis, because that could point more towards a hematological underlying myeloproliferative neoplasm? Or does the patient have any other enlarged lymph nodes? And then thinking about things like, do they have a murmur? Could it be an infection or infective endocarditis? And EBV as well, you might see abnormal liver function tests and an enlarged spleen and an acute EBV infection. Checking the immunoglobulins is also helpful. And again, considering whether testing for an autoimmune connective tissue disorder is appropriate depending on symptoms. So in terms of who to see, I think seeing anybody with a spleen size greater than 15 would be appropriate. Any splenomegaly with the systemic symptoms such as weight loss, fever, alcohol-induced pain, or any associated nodal enlargement. If they've got a raised reticulocyte count or a DCT or a raised LDH, or if they've got atypical full blood count findings. We don't need to normally review patients with a splenomegaly with a known alcoholic excess chronic liver disease or that are known to have portal hypertension. LDH, so lactate dehydrogenase, this is one of the most commonest kind of enzymes that is found throughout nearly all of the muscles within the, all of the tissues within the body, as it helps to enable glycolysis via an anaerobic reaction. Don't worry, there won't be any kind of Krebs cycle or the other one in this presentation. A single LDH measurement is has a really limited kind of diagnostic value, just for kind of just doing an LDH, just because you can tick it on the box. Really doing it, you kind of need to think about what is the process that you are thinking an LDH may be raised, because just testing on its own and it being raised doesn't really point to any specific underlying conditions. It's LDH can be raised. It used to be used before troponins came in terms of consideration for patients that might have had a myocardial infarction. It can be elevated in liver disorders, renal disorders, muscle disorders, and then obviously underlying malignancies, in particular lymphoma from a hematology point of view, and also hemolysis. So again, LDH being raised on its own doesn't point to it being a diagnostic of a lymphoma, but it is used within prognostic scores for patients with hematological conditions, as it can often reflect increased tumor mass or increased turnover of those cells, so normally a high-grade lymphoma. And again, in those cases, you would normally have patients with these B symptoms. And again, in hemolytic anemia, you would have other findings. They would be anemic. They would have often a raised MCV, and they would have typical blood film findings. And again, the liver, if there is any kind of acute hepatitis or jaundice, this can often cause a raised count. And in chronic conditions as well, it can also be raised. There's a lot of LDH in muscles, so people are obviously more aware now of the role of strength training in health, and the increased amount of kind of strength training, if you're having a leg day or an arm day, may depend, you're very likely to have a raised LDH the next day, depending on how hard you have worked. There can also be falsely raised LDH levels in samples that are hemolyzed, and that's because of the inside of the cells have all broken down and released the LDH, or if there's also a high platelet count, because again, high platelet count, those cells don't last very long out of the circulation, and they break down and raise the LDH. So it's all quite similar, really. You want to make sure that they haven't got any abnormal liver function test, their renal function test. The LDH is also in the kind of the screening tool for pancreatitis. So if they've got central abdominal pain, thinking about amylase, and then again, could it be an underlying hematological disorder from the lymph nodes and aplastic splenomegaly, and then the clinical history of any strenuous exercise. If they've got chest pain, maybe it needs to go down kind of the chest pain investigation route, and then looking for those red flags. So obviously we'd want to see anybody with a raised LDH and red flag symptoms on a 2-week weight pathway, or via an urgent discussion over the telephone, depending on what the patient's is like. An LDH associated with an abnormal full blood count, if you are concerned of hemolysis, or concerned that could be an underlying myelofibrosis, and again, that patient is likely to have an enlarged spleen. So minimally raised LDHs just above the normal level if they've got a history of exercises, or abnormally raised LDHs in association with other organ dysfunction, such as abnormal liver function tests or renal function, and no other cytopenias or abnormalities on examination don't need to be referred. I have done a little bit on lymphadenopathy, but I'm acutely aware of the time, and I'm happy to take any questions or go through that.
There is a question in the chat. I don't know if you've seen it for
Yeah.
from Helen McWilliams. For a patient with lymphocytes of 21, how urgently do they need to be referred?
I guess in that case, that definitely would have triggered a blood film to be done. So would the patient need, is there any indication on the blood film report? But I would happily see that patient on a 2-week wait pathway. But I would expect that that would have triggered a blood film. And there will also be guidance on that. Because in the lab, any lymphocyte count greater than 5 without a kind of a known diagnosis comes through to the haematology consultant authorization queue to be reviewed.
Okay, that's good to know. Are there any other questions from anyone? I'll try and have a look at raised hands or anything. I have to say, for me, I've been trying to write things down as I've been going. I'm really hoping we can have the slides for all of these because it's so helpful. But it's not, for me, it's not just been like a sort of list of numbers, it's the explanation behind it. And some of that I've probably forgotten because I'm getting a bit old, but some of it was really good to know. I almost feel like I sort of need them in front of me sometimes when I'm looking at blood tests at the end of the day, thinking, what do I do now? So it was brilliantly useful.
I'm very happy for my slides to be shared, and obviously there's always room for improvement, and actually just having that easily accessed for everybody kind of via an online system is something that is definitely being kind of worked towards through the lab. So hopefully things are just going to carry on being added to, so they are kind of more available.
Yeah, no, that's been really useful. I do try never to tick the LDH box because I always think I don't know what to do with it, so I'm sort of I feel reassured that I don't need to tick it, so that's all good.
I don't think it's necessarily needed, and again, when people are being kind of referred, there often are kind of loads of tests that have been requested by the GP, which is brilliant and can sometimes help there and then, but also we repeat them as well. So there's also shouldn't be any pressure to be thinking about, oh, I'm referring them for a lymphoma, I need an LDH or anything like that. So.
That's great. If there's no more questions, I think we'd all like to say thank you very much to all the speakers this afternoon. It's been just so informative and so helpful. It's one of the big things we get asked about is blood test results. Can we do some training on that? So I think you've addressed all our queries. So thank you very much indeed. Thank you everyone for the time. It's been brilliant.
Thank you for having us.
Thank you. Pleasure. Thank you.
Thanks, Dr.